So this is the topical phaco-emulsification case of NS3 cataract. I gave my the first side port incision, and with the trypan blue dye we are staining the anterior capsule, and now we'll just wash it out on the trypan blue dye, and I'm injecting viscoelastic substance into the SC and placed a bit of the visco over the cornea so that I can have a clear view. Now I am, with the help of cystitome, doing the capsular axis, and here the exercise is almost around 5 mm. I usually do 5 mm exercise, not larger, not smaller, because smaller axis will definitely will cause capsular phimosis syndrome, and larger axis will definitely have so many other disadvantages, like the nuclear fragments will slip out of the capsular bag, then there will be not very well centered PCI well, like that. Now we are hydro dissection we are doing, and that's a very key step for any cataract surgery, and with a good hydro dissection we can free the nucleus from the surrounding attachments. Then we'll slightly rotate the nucleus so that it will get totally free from the adjacent attachments. So here I'm just making a small groove. I'm just catching hold of the nucleus, doing my first job. See how nicely it got separated. So if we make a trench or a groove at ideal depth, then easily we can proceed the further step easily. So now each heminucleus I am dividing into further smaller fragments. The first chop happen means the main tension is over. Then further each heminucleus we have to divide it into further small nucleus for small fragments. Then I'll bring them at the plane of the iris and emulsify. I never emulsify them at the in the SC. Always emulsify them at the plane of the iris. That means, or maybe little below, but never in the SC. I'm emulsifying the fragments. The last fragment. Yes. It's a topical case, and the patient is slightly squeezing the eye. And then cleanse the brain. So now we'll go for bimanual irrigation and aspiration. Never ever drag the cortex, always catch hold of the cortex at the junction, then do a swiping movements. See how swiping movements, then bring it to the center and aspirate. Never ever just drag, no, swiping movement, like this swiping movements, so that it will get smoothly pulled away from the attachment. See, I'm just doing a swiping movements and bringing them to the center. I'm not aspirating them at the periphery, bringing them to the center, and then aspirate. Keeping only at the irrigation mode, I did little polishing of the posterior capsule to remove the PACC part, the opacities. We'll inject the IOL. See, you have to see how nicely the lens. Now we'll dilate and put the trailing haptic also inside the posterocapsular bag. Yes. Just hydrate the side ports. As it's a topical case, the patient is slightly squeezing the eye now.